Next speaker is Dr. Shreesha Kumar. He will be speaking on intraoperative distal membrane perforation during DALK-Our results.
Good afternoon, everybody. My paper is on intraoperative DOM perforation during deep anterior lamellar keratoplasty. We all know deep anterior lamellar keratoplasty has gained popularity amongst all corneal surgeons because of the inherent advantages this particular procedure offers to the patient as well as to the surgeon. And however, it requires expertise, and it's a difficult procedure, and you can end up having a DM perforation during the surgery. And if you are able to manipulate and do some maneuvers, you can continue with the deep anterior lamellar keratoplasty. Otherwise, we may have to convert it into penetrating keratoplasty. So the purpose here is to analyze both functional and anatomical outcome of intraoperative distal membrane perforation during DALK. And we included 16 eyes with perforation, of which 9 had advanced keratoconus and 2 eyes had advanced keratoconus with scarring, that is post hydrops. 2 eyes had keratoconus with Bowman scarring, and 2 eyes had macular corneal dystrophy, and 1 with pellucid marginal degeneration. And during this period, we have attempted DALK in 169 eyes for various indications. And coming to the surgical procedures, this is a case of advanced keratoconus with the stromal scar, and we attempted big bubble technique in almost all the cases, but one case with advanced hydrops, post hydrops corneal scar. And in this particular case, we got a big bubble on a third attempt, but there is a perforation which has happened at the end of the big bubble formation. There is a type 2 bubble formation, and there is a perforation. There is 2 air bubbles which entered into the antechamber, and I went ahead with the manual layer by layer dissection. With centripetal dissection, I could complete deep anterior lamellar keratoplasty in this particular case. And the patient did very well after the procedure. It is a pre-decimatic DALK. I could not reach up to the decimates. And another case, this is a case of advanced keratoconus, wherein this is a post-healed hydrops. Of course, I should not have attempted big bubble technique in this particular case. This is one of my first case, and I went ahead, but luckily I could maintain the chamber throughout the procedure, and could complete deep anterior lamellar keratoplasty. And however, I realized that these post-hydrops scarred tears usually will not enlarge. This is my experience of 4 eyes, wherein I could maintain anterior chamber and I could complete. This is another case of advanced keratoconus, wherein I had a perforation, but most of my dissection was complete, and I could continue with the DALK and could give good result in this particular case. So this is how they appeared after surgery. This is 6 months follow-up of the first case. You can see a scar here, but it has sealed very well. The second case, which had a scar, which is a paracentral scar, and patient did very well optically. And this is another case of macular dystrophy. This particular case had perforation right at the beginning. It was a very soft eye, the post-vitrectomized eye. I injected air bubble directly into the antechamber. Then I changed my direction of the needle, and I injected air into the stroma, and I could complete the procedure by doing a manual dissection, and the patient did well. This is another case wherein the perforation occurred almost at the end of my dissection, and I just changed the position of my dissection. I just moved away from this tear and continued the remaining dissection, and continued with the deep anterior lamellar keratoplasty in this particular case. And this is the post-operative picture. There is a small tear here which is sealed, and this is what is seen. It has sealed very well without a scar. And we included patients between 16 to 58 years of age, and the study was conducted between 2009 to 16. And we followed them up at 6 weeks, 6 months, and 1 year. The perforation occurred at different stages of the procedure. 7 of them had during formation of big bubble, and 7 during manual layer by layer dissection, and 1 had during slashing, and 1 during suturing. The patients improved significantly. Visual acuity improved from 1.07 logMAR to 0.25 at the end of 1 year after all the sutures were out. And there was a significant astigmatism, but it had significantly dropped down from 5.24 to 3.6 diopters, which was significant p-value. And post-operative endothelial cell count had decreased. It was almost 8% in the first 6 weeks, and it has gone down to 15% at the end of 1 year. And we compared this with the published literature by Lesisotti et al., which was published way back in 2007, and the results were comparable. And we had complications, and intervention was needed in 2 eyes, and air bubble release was needed in 2 eyes. So with this, I can conclude stating that DALK is definitely a dramatic choice for patients having a disease of the anterior stroma. And perforation is a difficult problem, but with proper intraocular management, we can have encouraging results. Thank you very much.